The proceeding will start shortly. 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 The proceeding will start The proceeding will start shortly. 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 The proceeding will start shortly The proceeding will start shortly. 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 The proceeding will start shortly.
Style, who is director at the Department for Health and Social Care. We are on quite a tight timescale because we've got votes expected at 6 and we're going to wrap up by then. So if it's all right, we'll crack straight on, and I wanted to we'll give everyone a chance to ask questions, but I wanted to start with some questions on the elective recovery plan, which is rumoured to be due to be published this week. And I just wanted to ask you, it's going to be funded through around £10 billion a year for the NHS that's going to come from the Health and Social Care Levy. Do you still support the Health and Social Care Levy?
Yes, I do. And it's very important that we make sure we've got the long-term funding in place for the NHS and for social care. And obviously the levy is about that long-term funding, and that's why it was set out in the SR. But especially the funding around it is also true that the extra funding that's needed to particularly tackle the electives backlog is hopefully a sort of temporary increase in electives, and we'll get through a lot of it over the next few years. But the increased spending because of the more generous means test in adult social care and the new cap that will be introduced in adult social care, that's longer term sort of structural increase in spending, and there should be a proper way to pay for that.
In all the discussions that are in the press at the moment about delaying the introduction of the Health and Social Care Levy, no one in the NHS and care system need worry that the £12 billion a year that it's going to be raising from April is under threat.
The funding that's been announced for NHS and adult social care over the SR period is secure.
Thank you. Will the elective recovery plan, when you publish it, address how we're going to find the 4,000 additional doctors and nearly 19,000 additional nurses that the Health Foundation say is needed to do the backlog operations?
Well, first, just a word about the electoral recovery plan. First, why do we need a plan? Because the impact of the pandemic, and we've seen, sadly, the waiting lists have risen. They're around 6 million at the moment, the elective waiting list. And as I've said before to your committee, and I've been very transparent about it, I expect the upward pressure on that to continue as more and more people come back. People that stayed away from the NHS, we estimate at least 7 million stayed away because they were asked to. Perhaps also there will be an impact, I'm sure, because of the Omicron wave as well. But we want these people to come forward. And in doing so, we've got to be prepared for a substantial increase in elective activity to get through as much as we can. A number of things are going to be required, new ways of doing things we may get onto in a moment. But of course, workforce is going to remain absolutely critical. So certainly the extra spending that's been allocated to the NHS over the SR period, I think it's around £15 billion thereabouts for the NHS over the 3-year SR period from the levy. But I think in total, the extra spending, so not just the levy, but in total, is around £23 billion. And I would expect a substantial amount of that also to go towards workforce.
So my question is not about the funding, which we recognise is there. It is about whether the elective recovery plan, when it's published, will say how many extra doctors, nurses and other frontline workers you expect to be needed to cope with the backlog in operations. Are you going to detail those numbers, and are you going to say how we're going to get those extra numbers?
It will talk about the importance of the workforce and
but
the
will
plans.
it say how we're going to get the extra doctors, nurses,
yes, but
workers?
But there are already a number of initiatives in place to get more doctors, to get more nurses. In the last year, for example, we've been successful at getting, I think, some 4,800 more doctors, 10,900 more nurses. And we do need more, and we've been very clear about that. And we will set out, not just in the elective recovery plan. I think separately we've also got the Health Education England working on a framework for the workforce, and through other ways we'll set out how the major challenges in terms of workforce for both healthcare and the regulated adult social care sector, and how we intend to address that.
Okay, and will the elective recovery plan also address the pressures in the social care system, which mean that there are around the same number of beds inappropriately occupied in hospitals by patients who can't get their social care package and can't be discharged, as there are COVID patients at the moment?
The plan will refer to the importance of that integration between elective care in the NHS and social care. But I think probably what's more important in addressing that is that we will also shortly be publishing a adult social care and NHS integration white paper as well. And that, I think, is going to be part of the sort of important set of reforms we need to make to make sure that we're just getting much more joined up work and a much more improved system between NHS and adult social care.
Okay, just a final one on the kind of short-term pressures. Obviously, the money from the levy, the extra 10 billion going to the NHS starts from April. So there are lots of long-term pressures with workforce and with the social care system. But from next April, when it comes to recruitment, some people say that we should continue the suspension of the 16-hour rule to make it easier for people who've just retired from the NHS to come back into the workforce. Some say we should cut the visa application fees for overseas doctors and nurses, extend the workforce retention and recruitment fund. Those kind of short-term measures alongside short-term measures to help people get home who are stuck in hospital, need to get into the social care system. It will have those short-term measures in place so that from next April we can really get cracking.
I think these kinds of measures are important, and you mentioned the 16-hour work rule. There's the rules around pensions, some visa changes, some more recent ones we've announced as well for the social care sector, and also for the NHS there's also the emergency register as well, which I think around 50,000 people have come forward and registered, and so all of this is important in our thinking to make sure that we've got the workforce that we need, looking ahead for the challenges that lie ahead.
Okay, thank you. And I just wanted to move on to some slightly more strategic questions about workforce before moving on to my colleagues. So last year on the 8th of June, we published a report on workforce burnout in the NHS and social care systems. And in that, we quoted a figure from NHS providers that said 92% of trusts have concerns about staff wellbeing, stress and burnout. 92% of trusts. But 6 months after that report, we still haven't had a government response to it. Why is that?
Well, I mean, first of all, can I say, in terms of workforce, that let me just, I mean, I've said this before, but I can't say it enough, and that how incredibly hard the NHS and social care workforce, they work in normal times, even before a pandemic, but during the pandemic, they have really risen to the challenge and performed with distinction. And that means that for all of us, whether certainly obviously this department that I represent, but for parliamentarians generally, I think we all want to do and have a duty to support them in every way that we can. In terms of responding to the work that the committee did, and thank you for that work, we will. I mean, it doesn't mean there isn't work going on to support the workforce, the resilience of the workforce. There's plenty of work that's happened and that will continue, but there will be a more formal response to the report. Now, I can say a bit about the work that we've been doing. We have a people recovery task force.
We'll do that, but can you also understand the scepticism people feel about the government's real commitment to this issue if it takes 6 months to respond to a select committee report? We understand there's a pandemic and we've been flexible with the timings of responses, but workforce is the number one issue across the whole NHS, and for us not to have had a report 6 months later is a big concern.
There shouldn't be any scepticism because of the evidences in the work that we are already doing. So, for example, I was about to mention the People Recovery Task Force that we have set up, because even before the pandemic, there were a lot of workforce pressures that the committee and members would have recognised. It's got much more challenging, of course, because of the pandemic. So the work that we've done on both physical and mental health support, work on retaining staff, creating the time and space for staff to make sure that they can have time to sort of reflect and to take rest and respite, the well-being guardians that we've introduced at board level, and the investment in well-being, including well-being conversations, proactively asking people in the NHS in particular about what further support can be provided. So I'm no way suggesting at all that this is enough. I think we need to absolutely keep working on this, and the work that you've done as a committee will be important, and we will respond.
So let me ask you another question. The training for NHS staff is funded by Health Education England. Yep. Last time you were with us, you said you'd only just got your settlement from the Treasury and you would now set HE's budget for the next year. Yep. Has that been done?
It has, as far as I'm aware, it's not finalised at this point. It's almost done. It's not finalised at this point.
So,
but it of course will be in advance of the start of the financial year.
The biggest concern facing people in the NHS. HE is the body. It's going to be merged into NHS England, but it's the body that funds the training of new doctors and nurses. So the numbers of new doctors and nurses we train is decided by HE, and the financial year starts in 2.5 weeks, and we still don't know how much money they're going to get. Can you understand why people, again, are sceptical about the nice words the government says about workforce when something as central as that has still not been sorted out?
Well, I wouldn't. Of course, it is hugely important you set the budget in time, but the budget will be set in time. It's a number of discussions have gone on with HEE and NHS, of course, as well, especially in light of the forthcoming merger. And I think once that is complete, we can set the budget. In the meantime, the work of HEE and NHS on workforce continues. So it might be helpful to point out that over the last year, if you look at what's changed in the workforce, that 44,700 more people in the NHS, and that's the increase in the workforce. In terms of doctors, at around 127,000, nurses at 310,000-ish. That's the highest number for both doctors and nurses we ever had. And in terms of, if I look at doctors at medical school, last year's entry at something like 4,000 was the highest number ever. So we've got a real sort of a good pipeline of GPs, potentially other types of doctors, and also dentists going through medical schools. I think dentists record numbers as well. So a huge amount of investment is going in.
Simon Stevens yesterday in the House of Lords recognised that there have been increases in the numbers of doctors and nurses during the pandemic. Yep. He said that was very welcome, but he used a very strong phrase to describe the government's refusal to do long-term workforce planning. He said it was willful blindness. He said the government had known these issues were happening for a long time, over several years, but at every stage had refused to support Health Education England to do that long-term planning, and still now was not even setting Health Education England's budget. What would you say to that phrase, willful blindness, used by Simon Stevens, the man who used to run the NHS?
What I would agree with him, and I did read his remarks after he made them, is the importance he attaches to the workforce and the need for a long-term plan on the workforce. I absolutely agree with that, because we do need to look, so if we're talking specifically about the NHS, but it applies very much to social care as well, but focusing on the NHS for a minute, that when we try to sort of look at the demographic changes in the country and obviously the impact of the pandemic, the new sort of medicines and treatments that we'll have, new ways to diagnose people, we obviously want to make sure we have the workforce for that. So what have we done about it? So the bit I wouldn't agree with is the sort of idea that there's no, the government doesn't have a plan to deal with these workforce pressures. Back in July last year, I commissioned HEE to do what I called a sort of a workforce framework to look at the key drivers and trends in workforce, to look at the skills that are needed, the longer term training, the values that we want to represent and see represented through our workforce, what should be the sort of shared assumptions throughout the system, not just HEE, but NHS and other parts of the wider health and social care system. But the other thing I can tell you, one thing I've also recently done, and happy to tell the committee, I recently commissioned the NHS to develop a long-term workforce strategy. Now, that hadn't been done before because I wanted to kick off the work first with HEE. Hopefully they'll report in the next few months. They've done a lot of work on this, and I wanted that framework then to feed in to the NHS. I think the fact that we're doing the merger now with the HEE and NHS will help a lot and make the whole thinking around workforce much more joined up. But having now commissioned NHS to do this long-term workforce strategy, something I hope that committee members, Lord Stevens and others would welcome, I think is the right way forward.
So, final question from me on this. So this committee has suggested the way through this is a very simple one, which is to ask a body, it could be Health Education England, it could be NHS England, to do independent forecasts of the numbers of doctors, nurses in every specialty that they think we'll need in 10, 15, 20 years' time. And we proposed an amendment to the Health and Care Bill that was voted down by the government on the 23rd of November that would have done just that. Can I just draw your attention to a letter that the then DHSC Minister Nadine Dorries sent to me on the 22nd of April last year about midwife numbers, because it tells a slightly different story. She sent a very detailed, very good letter in which she said that there were 844 unfilled midwife posts, but that the government had used an independent tool that was endorsed by the Royal College of Midwives called Birth Rate Plus. And on the basis of that independent tool, on top of filling the 844 places, there needed to be another 1,088 midwives. And she was then going to put £95 million into funding those additional 1,100 midwives. So a really scientific process was put in place to tell us exactly how many midwives we need and to fill the gap. Now, if that is good for midwives, why not for obstetricians, anaesthetists, doctors in every single specialty? Why not for nurses across the system? That's all we're asking for. What's the problem with that?
Well, the example you just gave around midwives, I very much agree with that kind of approach, where how much we invest in the workforce, the numbers that we try to recruit in the short and longer term, it must be based on a proper analytical analysis based on the needs of our healthcare system. I very much agree with that. That was the reason for me to first commission HEE on the workforce framework it's doing, but also the reason I have asked a body, and you rightly say it should be a body, it shouldn't be, I don't think it should be my department directly. In this case, the body that I've asked to come up with a long-term workforce strategy is NHS England, and I do think that they're the right body to do it. And also, once HEE is merged into NHS England, I do think it is right that the organisation that will hire the workforce and pay the workforce and ask them to do electives and other work is the same one that should be focused on their training, on their hiring, and all of that as well. I've never quite understood why HEE was a completely separate body, although obviously part of the government, but to NHSE, and it's right that it's merged. And I think that, along with my ask of NHS England, would lead to an outcome which is very much like the example that you gave.
Thank you. Sarah Owen.
Thank you, Chair. I'm going to move on to social care workforce, since workforce seems to be word of the day. With the unprecedented sick rate combined with the over 100,000 shortage of care workers, it's putting immense pressure on existing staff. Why is there no equivalent of the NHS People Plan for social care?
Well, there's a lot of focus on adult social care workforce, and we have different names for different types of initiatives. But I would point as one real sort of very recent example is the work that we've done and set out through the white paper. So the white paper on adult social care that was published very recently, where we set out it was actually called the People at the Heart of Care white paper, which has set out how, for example, we're going to use about £500 million from the levy that was mentioned earlier to have a better training for that workforce, to make sure that it is given the support that it needs and it's sustainable and it's a more recognised workforce.
You will have a people plan for social care?
Sorry?
So you will have a people plan for social care?
Well, that is. I think you can have different names for it, but there is already a plan in place for the adult social care workforce. Is what we set out. The longer term view is what I've pointed to in terms of the white paper. Separate to that, there's been a lot during the pandemic, including more recently in the last few months with the extra spending, the funding that was given to the adult social care sector. I think the 162.5 million retention fund for that workforce, plus an additional, I believe, 300 million that was given at the start of the Omicron crisis.
Thank you. I've got a couple more questions, so if
Sure.
you could keep the answers and questions short.
Yeah.
Your department's adult social care workforce survey showed over a quarter of care workers were leaving because of pay and over 13% because of working conditions. So terms and conditions and pay are a big concern for care staff, especially for overseas healthcare workers. How many care workers have been refunded the immigration health surcharge since the Prime Minister made that promise? And will that refund continue for all healthcare staff in the future, or was it just for the duration of the pandemic?
I couldn't tell you how many have been refunded. I don't have that number with me. I'm happy to write to you and share that with the committee. You're right to, of course, point to the importance of pay across health and social care, but I think some of the recent changes, for example, the announcement of the increase in the national living wage, I think a 6.6% increase, that will help.
And the national living wage is still in poverty pay. It's not actually a living wage that you can live off. And still there are a number of care workers that are not being paid for in between travel times. Is that something that you will look at?
Well, the national living wage, the increase in national living wage, I think will help anyone that is on that wage. I'm sure that they certainly would welcome it. You'll know that the workforce in adult social care, as opposed to the workforce in the NHS and health more generally, is not directly employed by government, or even indirectly. There are independent employers in the private sector that obviously the government does have a say through national living wage and in other ways. And the second part of your question? Sorry.
It's about whether you're going to have the immigration health surcharge refund scheme, whether that's going to continue into the future or whether it was just for the duration of the pandemic.
It was a decision made during the pandemic, and it's something we keep under review. I couldn't commit to you now whether we're going to keep it or not.
You can understand that hundreds of pounds for healthcare staff
Yes.
that are on the minimum wage is a huge amount of money,
course.
and I think it
I
would be
understand
really
that.
good if they could understand whether it's going to continue into the future. I'm just going to move on now,
Yep.
and it's about a specific question about the pandemic. What practical changes have been made to ensure, if there was another pandemic, that infectious patients would not be released back into care homes as we saw during the COVID pandemic?
I think it's fair to say that during the pandemic we have learned a lot, the department, NHS and social care. And what I would point you to is how the government responded to, in terms of the changes, and you asked about practical changes, how the government responded to the Omicron wave. So, as you know, very recent, and because of what we'd learnt, the infection protection control guidelines that were in place, some of the contingents we had in place, we were able to act very quickly with care homes in enhancing the PPE requirements, changing the visiting arrangements, and also one other big difference, I think, today compared to the start, notwithstanding obviously the vaccines and making sure that everyone in the care home, all the residents and the staff are vaccinated, but also the testing regime that we have as well, which, as you know, didn't exist, anything like that. There's no such thing as a lateral flow test, for example, for COVID at that time. But now with the use of tests and the PCR tests for the residents on a regular weekly basis, I think this is a set of protections that exist. And I think we've seen the positive impact of those in the last few weeks with the Omicron wave.
Just a short, quick one related to that point. You would have had a chance to see the recommendations from the COVID inquiry from the Joint Select Committee. How many of those recommendations have been put in place?
I couldn't tell you specifically. We saw the recommendations. A lot of that would have, some of it may have already been in train, some of it would have been put in place, but I couldn't tell you exactly how many of the specific recommendations.
And the last one, because I'm pretty sure that it's in everybody's inbox, is around access to GPs. 111 increasingly across the country is being used if you want to speak to a GP or to see a GP. This was not exactly what 111 was originally designed for. Is this a permanent change in the use of 111 service, or is it until we see an ease on the health services generally? And is there an ongoing review of it?
It's not a permanent change. I think what you're referring to there, the increase in 111, is really a reflection on the impact of the pandemic. Because in the early days of the pandemic, when we had all the social distancing rules in place, obviously people couldn't see their GPs in the normal way, and also they couldn't go to hospital in the normal way. For example, people were even reluctant in some cases to go to A&E, and I think they're more likely to use the 111 service. Also, very recently, as in the last couple of months, because of Omicron, because we rightly asked GPs to focus on the booster drive, the need to get so many more people boosted, especially in the month of December, GPs were asked to only focus on urgent care other than the work on vaccinations, and I think that's been reflected in 111 as well. To help with that, we have provided extra funding to 111 services, and I believe it was in the winter it was around 75 million. Don't hold me to that, but there was a significant investment we made in 111 services and to GP services, the £250 million winter access fund.
If that's the case, why is it that our inboxes are so full with people saying that they cannot see their GP?
Because I would say probably if it's in the last couple of months, especially, is because the GPs have rightly been focused on the vaccination drive. There's only so much GPs can do, and let me say, I think GPs have been working with distinction throughout the pandemic, and whenever they've been called on, look at the recent booster drive we've seen when they were asked to visit care homes and homebound people to vaccinate them, they responded incredibly well, and that's made a huge difference. But because they've been focused on that, I think it's been harder to access GPs in the normal way. I think people would understand that. I think people would understand it was right to focus on the vaccination drive. That said, now that, and hopefully if Omicron continues to with case numbers falling, hospitalizations falling, then GPs will have more time to sort of behave in the usual way, especially with the support of the Winter Access Fund.
On which point we will go to our very own resident GP, Dr. Luke Evans.
Thank you, Chair. And on COVID, Secretary of State, what's the probability of there being another variant that we may well need to take measures for?
I think there will be more variants. I mean, first of all, let me answer it this way. Will there be more variants? Yes, absolutely. I mean, there's been loads of variants of COVID, and most of them, thankfully, we haven't had to sort of worry about. I think we have probably the best surveillance system in the world in the work that the UK HSA does, and we saw that with Omicron. Your question about a variant that we'd have to worry about, I think there likely will be a variant that will be trouble in the future. And actually, by the way, there's already, we know about a sub-variant of a sub-lineage, let's call it, of Omicron at the moment, BA2. We're not particularly worried about it, but just to sort of Dr. Evans just to mention just how how we've just got to stay on top of this all the time. BA2, if you look at the case rates in Denmark at the moment, is spreading very, very rapidly. There's absolutely nothing to suggest that the vaccines aren't effective against it. It seems it's just as contagious as the original Omicron, BA1. But it's a reminder of the importance to stay vigilant, but also to stay vaccinated.
It's really helpful, because that being said, and we've heard it time and time again, moving to live with the virus. So what plan does the government have to avoid going into various lockdowns and to have a broad consensus of how we put measures in place for the future, should we need them?
Yeah. As I've said, the Prime Minister said we've got to learn to live with COVID. I think we're learning more all the time, and we've put a lot of that into practice over this recent Omicron wave. We will, first of all, I will be setting out, hopefully, next few weeks, a sort of plan in the spring, by the spring, a plan on how we think in government that we can learn to live with COVID as a country. And
that's really true. So you're going to come forward with a variant plan, which would have different, what level we put in masks, what level we put in social distancing, what level we need to close schools, all this. Can you talk us through how it would look? I wouldn't describe it
as a variant plan, or even necessarily on the kind of measures that you suggested there. But I think it will set out, taking into account everything we've learned over the last couple of years, what is it that we know is most effective, and then also understanding that, in the early days when we had the sort of lockdowns and things with the pandemic, that what are the sort of the knock-on non-COVID impacts of that as well on things like education, so children's schooling, college and university education, people's life chances, not going to work in the usual way, and all of that, and also the non-COVID health impact as well, your mental health impact, for example. So I think the things that we will focus on will be absolutely the pharmaceutical defences. So vaccines, I think, are with us to stay indefinitely, and I couldn't tell you today how often we would recommend a COVID vaccine, or exactly to what cohorts we would, but I don't think they're going away. Antivirals and other treatments, which again we have today for COVID that didn't exist when we first learnt about COVID, and also testing, I think, will continue to form a big part of our response. So those three things I would sort of put at the top of the list: vaccines, treatments such as antivirals, and testing.
So let me pull that together and say that's the pillars that you've got. It sounds to me for the first time we're going to be pulling together effectively the economic impacts, the non-COVID, as well as the COVID side. How will that be drawn together, because you are the Health Secretary? How does that involve the Treasury, BEIS, all the other representatives, education of these areas, to fully formulate a plan that can deal with us and be sustainable for the future, to hopefully protect against the foreseen problems that we might have?
I think my department will lead on this. I will lead on this as the lead minister, but of course it will draw in from across government. It will be a government response to how we learn to live with COVID. And I've said, and I think I've said it recently just in the House in my last COVID statement last week, that we've got to find a way to live with it in the same way, let's say, we live with flu. And I'm not for a second sort of saying it's like flu. It's look at sadly all the deaths we've had from COVID, over 150,000 from the start. It's about understanding we do now have defences which we didn't have before, and just as sort of flu doesn't stop society and stop life, we mustn't let COVID do that anymore.
So my final question then is, with regards to that, how do we ensure that the NHS has the time to relax and deal with the backlog, but be able to scale back up yet again like we had over the Christmas period for the Omicron? That's a tough ask for the staff and the NHS in itself. What's the approach that you'll use to deal with that?
Well, it is a huge ask. I mean, first we must recognise that, because the NHS has all its sort of, let's say, its pre-COVID work to be getting on with, and also obviously that's increased as well. For example, the electives, the sad increase we've seen in mental health challenges as well, and of course the NHS has to deal with that as well. At the same time, it has to be preparing for living with COVID. And how do I see that? It will be set out in this plan, but to give you a sense of that, part of it is these pharmaceutical defences. So vaccinations. What we can't have every time we're trying to encourage people to take a COVID vaccine is we can't, if I refer to the previous question from Ms. Owen, we can't have asking GPs to stop doing their regular work. We can't have that. That can be an emergency response now, but in the future we've got to have a national, let's call it a national vaccination service that is able to deal with COVID vaccines as well as other vaccines without drawing in sort of workforce from the rest of the NHS. That's one thing, and the same applies, by the way, to you're making use of antivirals and testing and sort of having a separate process to deal with that. The other thing I think we need to think carefully about is what I would call sort of surge capacity. So we have again learned over the last couple of years. You would know about the nightingales at the start of the pandemic. This time we did it a bit differently with the on-site nightingales. But I think we've got to have some system of surge capacity that's sort of pre-planned, pre-thought through, so that it can sort of be in abeyance, when most of the time. But if there's a new wave and there's a concern around capacity, we can quickly switch it on.
Thank you. And from our resident GP to our resident pharmacist, Taiwo.
Thank you, Chair. Secretary of State, as a West Midlands MP, I'm sure that you're aware that some hospitals in the West Midlands have the worst waiting time in the whole of the country. Now, data from University Hospital Birmingham shows that they have the longest waiting time of any trust in England. So what steps are you taking to level up what seems to be a postcode lottery when it comes to waiting times?
Yeah, thank you. Well, so when we look at the elective waiting list, which I referred to earlier with the chair, the size and the sort of direction, that it is right that when we look at that we properly, this is what we will do in the elective sort of plan when we set it out, is that we break it up in a few important ways. One is by region. So I don't have the exact numbers, but for example, the elective waiting list sort of weighted by population is lower in the London area and the southeast than it is in the Midlands and the northeast, for example. And so it's right when we direct resources that we take into account the regional differences and make sure in this case you're talking about the West Midlands that the correct amount of resources are there to reflect the need of that area. The other way that we will break it down, since you ask, and this will sort of apply, that we have regional differentiation in this as well, is by the length of time people have been waiting on the list as well, and obviously the longer someone's been waiting, particularly for certain types of procedures, that's got to be a priority as well.
Okay, I just want to quickly move on to workforce planning.
Yep.
On way of time. You've spoken a lot about nurses, you've spoken a lot about GPs, but I'm sure that you're aware of the work that physician associates do in terms of alleviating the pressure from doctors. So what's the government doing to ensure that we have sufficient numbers of physician associates in the country?
Yeah, we are we're talking to the Royal Colleges about physician associates and seeing what more we can do. There were some changes around some of the work that physician associates could do during the pandemic. We're looking at whether some of those changes should be made permanent. And then also, but when it comes to recruitment, the physician associates are as important as other areas in the workforce that we're hiring. We talked earlier about GPs and nurses, certain consultants, certain specialists, and that's a focus as well.
Just want to quickly move on to recruitment. So you spoke about how we have 4,000 new medical places that has that's come into place this year.
Yeah.
So what are you doing to address the fact that in many training places there isn't enough capacity post-graduation? So for example, in Coventry and Warwickshire, we have the capacity to take on more training places, but we don't have the necessary number of places. So what's being done to address that?
Well, I think the first thing I'd say, I'm pleased that we're able, for the last 2 years, been able to remove the cap on places and have more and more students entering new medical schools, whether for doctors or dentistry. And at the same time, though, we're looking at what should be the long-term investments in the training estate and training places, and that is part of the work that the HEE is doing. What I referred to earlier when I talked about the workforce framework, the 15-year framework that I've asked them to do, is to look at precisely this. So, are we putting enough investment in the right places to create those training spots and places that we need for the long term?
Post-graduation?
Yes.
Okay. And just lastly, I just wanted to talk about 2 medical schools within the region. So yesterday I spoke to the Vice-Chancellor of Warwick Medical School, and he spoke about how, as a medical school, they are willing to expand to help with the workforce demand. So what discussion are you having with the Treasury with regards to expansion of medical schools?
Well, first of all, I couldn't tell you anything specific about Warwick Medical School, and you probably wouldn't be surprised to hear there's probably there's quite a few medical schools that could expand if they had the resource and they felt they had the demand. And again, I would just point to the work I've asked HEE to do, because I think rather than sort of ministers or even officials in the department deciding that what the need is and where we should invest in terms of training places, that is the point of having the HEE sort of independently assess this. And in the spring, when that work is complete, we will publish that, and that will help us to set out our longer term plans.
Lastly, so another medical school that is waiting to hear back actually from the government.
Which medical school?
Chester Medical School is waiting to hear back from the government with regards to policy direction needed for it to start providing the necessary doctors that are needed within the NHS. So when is the government going to get back to them, because they have been waiting for a while?
I don't know about that particular medical school and exactly what's been communicated to them in the past, but if you allow me, I'll be happy to take that back to my department and get back to them.
Thank you, that'd be helpful.
Thank you.
So you'll be delighted to know that we're doing an inquiry into workforce matters, so you'll have plenty of opportunities to answer these questions again in the future.
I'm thrilled. I'm absolutely thrilled.
Dean Russell.
So thank you, Chair. Thank you, Secretary of State. And also, can I, through you, congratulate everyone for the booster programme, which was phenomenal over Christmas to get so many people through the NHS and volunteers and the whole team. I just wanted to touch on vaccination, mandatory vaccination of NHS staff. I'm conscious that the NHS is supportive of this. I've chatted to NHS workers who are very supportive. However, of course, it does mean there are many staff who aren't getting the vaccine, and when I've spoken to constituents who are concerned about this, they're feeling like they are being put in a difficult position because they feel that they've got the antibodies but they aren't getting the vaccination. And I just wondered if you could help me explain to my constituents who would like to say, can't they just be tested for antibodies to test their resilience to COVID rather than getting the vaccine? How would I respond to them, please?
First, thanks for mentioning the importance of the booster programme, and we are, just on that quickly, we are the most boosted large country in Europe, and that has been, I probably think, the single most important intervention in dealing with Omicron. And when you look at the directional travel of Omicron at the moment in terms of case numbers, hospitalisation, infection rates, all in a downward direction, there's been lots of important interventions, but the single most thing is boosters. And everyone that has stepped up taking their booster shots, some 16, 17 million people, I think 37 million booster shots delivered, over 90% of over 50s boosted, for example, in our country, more than any other country in Europe. That all those people have played a part in our recovery, every single one of those people that came forward. Now, when we turn to the NHS workforce that you asked me about and vaccinations, it's important for everyone to get vaccinated. We all know why, but I think it's especially important if you are in a profession like the NHS or out of social care where you're caring for vulnerable people. Your question specifically was around people that have asked you about, well, what if I've got prior infection? Do I still really need to get a vaccination? And the answer is that all the evidence is that even if you had a prior infection, if you get a vaccination on top of that, you're even more protected. You're more protected, obviously, for yourself, but you're also, because you're less likely to get infected than otherwise, it means that you're less likely, therefore, to infect others, and that means less likely to infect your patients who are already very vulnerable, because that's why they're in hospital.
And thank you. And can I ask, in terms of, obviously, the date is looming for when workers need to get their vaccination as part of this programme. What's the plan for filling that gap, as it were, if the number of people who say that they're not going to get the vaccination or currently haven't leave the NHS over the next few months?
Well, first of all, I'd start by saying it is regardless of the mandate for NHS workers, it is the professional duty of every NHS worker to get vaccinated. It is a professional duty. So even before the mandate, the vast majority had. Since the mandate, since we announced the consultation in September, we've had around 100,000 in the NHS that were unvaccinated at that point that have come forward. So there's been a very good response. I think now it's almost 95% of NHS workers that have had at least one jab. The latest numbers I have is there's around 77,000 that have not. That is improving every day. Not all 77,000 are in scope, because to be in scope, it's if it's a patient-facing role. But the majority of those people would be in scope. And I think it's also reasonable to assume that not everyone ultimately is going to come forward. So what the NHS is doing, and rightly they've contacted and in constant touch with every single trust and asking them for their plans, and they have asked every trust to set out those people that they estimate will ultimately just not come forward, and then to break down what kind of roles they are and see how they would manage that. But to give you a sense, and I won't name the trust, it was a conversation in confidence, but I spoke recently to a chief executive of a relatively smaller trust, just around 5,000 NHS workers in his trust. And he told me their vaccination rate was around 97-98%, very, very high. And a lot of that was improvement in the last 2 months, where there's a lot of rightly positive work, persuasion with people about the importance for themselves, for their patients. And he estimated he had around 200-ish that hadn't got vaccinated, but he's just completed a work where they've asked every worker if you're a firm refusal. I think he called it a firm refusal, and he estimated he's going to have about 25 out of about 5,000. Now that's just one trust. I don't want to pretend that's the same sort of proportions in every trust. I think in some areas there might be higher proportions that ultimately don't. But what we are seeing is that through persuasion and making it a positive decision, that more and more people are coming forward.
That's good to hear. Thank you. And just if I may just touch on a different topic, which is about mental health. You mentioned earlier about the work that's going in to support NHS staff, which is very good news. One of the areas that I hear a lot about is support for children, and in particular for teenagers. So we've gone through the challenges of COVID and lockdown, but also the early stages without seeing their friends in school and so on, and the potential ramifications for that into the future. I just wondered if you could elaborate on what the support's going to be in place now, but also long term, to improve mental health access for support for teenagers, especially as they start to go to university and perhaps are away from family as well.
Yeah. You would have heard me refer earlier to some of the sort of non-COVID health challenges of the pandemic, and sadly mental health is one of them, especially amongst young people, teenagers in particular. And that is why we are working on a refreshed mental health plan, because we've got the last one, a good plan, the long-term plan of the NHS was pre-COVID, and I'm working on with the NHS a sort of complete reset of that plan, and the funding commitment that we made for the long-term plan is still there to increase, to keep increasing NHS spending year by year. There was the extra funding and support that we got over the pandemic as well. But when we set out our reset of the long-term plan, which will be early this year, it will include a focus on mental health, but in particular for younger people.
Okay, that's good to hear. Thank you, Chair.
Thank you. I'd like to welcome a new member of our committee, Martin Day, for the next set of questions.
Thank you. Much of what I would have liked to have asked has already been covered. So
that's right then. Next.
But one of the issues that I was very pleased with was when the government announced the money for motor neuron disease research back in November. And I'm just wondering if you can give us an update on what progress has been made in allocating that.
Yeah, no, thank you, and welcome to the committee. Yeah, that was a really important commitment to me. That was making sure that we were setting out at least £50 million of spending over a 5-year period dedicated to motor neuron disease. And in terms of progress, what we've announced is all being put into place. So how the research will be, we will be asking for people to come forward, researchers, academics and others, on the kind of research they want to do. So the money will be allocated over time. And then also the partnership that we announced as well. So it's actually quite early days. in that we promised also that we would work with all the stakeholders to make sure that they have an input in how we set up the partnership, how the research is prioritised. That's the consultation phase that's going on at this point. Once we've got through that, then we will set out and publish in more detail how we will take it forward. I was very proud of that commitment, because I think for a long time, for a variety of reasons, we haven't really focused enough on this terrible disease, and by research, there are breakthroughs that potentially can be made.
Yeah, I think so.
And by the way, we also collaborate with other countries on this as well, so it's not just the funding we're putting in, but other countries that we'll partner with. If they come forward and make commitments too, we'll be able to collaborate on the research.
What's the timescale for this consultation phase coming to an end?
It's an informal consultation,
right.
So in our mind we thought we should take 3 or 4 months to work with the relevant stakeholders and then put together a more detailed plan.
Thank you.
Thank you.
Thank you. Barbara Keeley.
Thank you, Chair. I want to raise as a first question with you the detention of autistic people and people with learning disabilities in inappropriate inpatient units. There are 2,085 people in that situation, despite the Conservative government pledging 10 years ago to close all those units down. Now, I recently heard, I don't know if you've seen this case, but it got a lot of publicity, about patient A, a 24-year-old autistic man held for 4 years in a box-like apartment in Cheadle Royal Hospital and given his medication and his food through a hatch. This placement comes at a cost to the NHS of £20,000 a week. So my question is this, Secretary of State, why do you not act on this committee's report on this scandalous treatment and find suitable accommodation and support for all those autistic people and people with learning disabilities?
Actually, I think, again, like today, we've heard this is another very important issue. And I think I'm right in saying that this is something where rightly my predecessor had asked for a review of what more can be done here, with the principle being that in all these cases that someone should be cared for in the community as close as possible to their own family, perhaps with their own family setting, and not in these types of settings. You mentioned the patient A case. I know which case you're referring to, because when I heard about that case, and I will tell you, I heard about it through the media, yep. and I did immediately ask my office for an update on that particular case and the issue more generally, but on that case, because it did concern me considerably, like I'm sure it concerned you, and I was provided with that information, but I shouldn't talk about the detail of a particular case. I think it would be appropriate, but all I would say is that when you get the detail of that particular case and perhaps other cases, it's not as straightforward as it might seem, especially if you take into account that where people are not kept, are not sort of in the community, but they are in a sort of setting where they are detained, then there is usually there's either a clear clinical reason for that, and that starts by their own protection, or possibly for the protection of others, but also in many cases it can be people that may well be autistic or have another type of mental health challenge that have been directed by the courts to be detained, and so that is, and the courts are involved in how long they have to be detained. So, but in answer to a more broader answer to your question is that this is a thing that concerns me a lot. I've asked for advice on the current policies that we have in place and the outcome of the review that was kicked off by my predecessor to see what more we might need to do.
I could say to you that I've done a lot of work on this, particularly with your predecessor too. 4 years ago, there was a young woman called Bethany who also got a lot of attention in the media, and I raised her plight quite a lot here. And Bethany just had her 21st birthday living in an apartment in the community, happily with care and support. And yet Bethany was in a situation where she was held in a cell, fed through a hatch. So, you know, there are cases. But this really needs a complete change of pace, if you like, because it's 10 years, more than 10 years since Winterbourne View. And this committee has written an excellent report on this. Our response to that was due from you in September. We haven't heard anything from you, and just nothing is moving. And I understand, newly in your role, you'd asked for a review of this, but there've been reviews and reviews on top of reviews. And people out there who care about this are sick to death of reviews, and the parents, like the parents of the parent of patient A, who go to the media to try to get something done about it, are just worn down with, are talking about it and talking about it. It actually needs to change. And more than anything else you could do as Secretary of State, you wouldn't, the alternatives, most of the alternatives in accommodation in the community are cheaper. We shouldn't be spending £20,000 a week to keep a young man, an autistic young man, being fed through a hatch in a hospital. We shouldn't be doing that, because that's £1 million a year, and that's ridiculous.
Yeah.
So, I'm hopeful that we start to see a response from you, but this absolutely is something that has got to change, and it needs some determination from the person in your role to do that.
Yeah, look, I'm pleased you raised this. This is a very, very important issue, and whether it's the young man, patient A, or young woman, Bethany, you refer to, of course, there's always a financial cost to this, but it's much more than the financial cost. It's about doing what's in the best interest of these individuals.
But there's no financial reason not to do it. That's the point I was making.
Yeah, and there may well be a financial reason as well, but it's about starting with what's in the best interest. Yeah. And I can assure you, it is a hugely important issue for me, and I have asked for that review. I'm afraid I couldn't give you the detail of everything that's happened before me on this, but it is because of some of the recent news around this. I asked for that review, and now that you've raised it, it's made it even more important for me, and I also make sure that we respond to your report.
Thank you. I want to talk to you about carers working in the NHS. Not social care staff, but people who are themselves in their own time carers. 1 in 3 NHS staff is actually juggling work and care. So the NHS work and care for a family member, according to the NHS Workforce Survey of 2021. That is actually a very high proportion. So you have a high proportion of your NHS staff who are carers. But the current lack of social care is putting pressure on all staff who juggle work and care. Pressures increasing due to underfunding, the shortage that you know about and have talked about with my colleague Sarah Owen of paid care staff. Carers UK are now reporting that 1 in 5 staff risk having to give up work to care if they can't get accessible and affordable care. So what I wanted to say to you is lack of care is putting pressure on NHS staff, and it could cause large numbers of them to give up work to care, increasing those NHS workforce issues that you've talked about earlier, and recruitment and retention costs. Well, my question is this: what can you do to ease that pressure on NHS staff who are also unpaid carers for a family member?
Yeah, well, I think it's an important issue, and it's important for obviously the group of people you talk about, which are NHS workers that also have caring duties outside their NHS work. But I'm sure there are other professions as well where people are doing important work and they have similar responsibilities. So I recognise it's wider than just NHS care people with caring responsibilities.
You've got the NHS workforce to worry about rather than
we do. But as a government, we should be concerned about workforce more broadly as well, because of these sort of caring pressures on people. What are we doing about it? It's I would just point to the work on in improving the adult social care system and the work on workforce. I referred to earlier, for example, the adult social care white paper we published, which is about the long-term investment in the workforce, the extra 500 million I referred to there.
Didn't
but
touch
in
on
the
pay, though, did it? There wasn't. I mean,
no, that didn't touch on pay. That didn't touch on pay.
Because that is a big issue, and it's worth saying.
But to touch on pay, I also mentioned earlier in the sort of more immediate term, whenever the national living wage is improved, that is the 6.6% increase is helpful to anyone in the care system, certainly helps with recruitment, but also the extra funding we've put into recruitment this year, on top of the regular funding in adult social care. So the 162.5 million retention fund that was for this winter, the extra funding on top of that, the 300 million because of the Omicron wave, and also the support we're providing through the NHS indirectly through the discharge fund for the NHS, almost £500 million extra given to the NHS this year, so they can support that to top up payments from local authorities and others to care homes or to domiciliary care workers, so that it can help with their own delayed discharge problem. So there is short-term funding going in and a long-term plan, which is in the Adult Social Care White Paper.
We're making excellent progress, but we're hearing the vote might come before 6, and we've still got 3 colleagues. So
just
very brief final one,
final
Barbara.
comment. Yes, I just wanted to add to what my colleague Martin Day has already said to you about the £50 million for the Motor Neuron Disease Research Institute. Clearly that's not needed, but you will appreciate the time is of the essence for people with MND.
Absolutely.
Half of whom will die within 2 years of developing symptoms, and there's so much energy to give that a boost, and yet I'm afraid what you said sounded a little slow. I just wonder if, I want to add my voice to saying if you can speed up on that, that would actually be...
we're doing everything we can to speed that up. And I think just the fact that we were able to make that a commitment for the first time, I think the biggest commitment we ever made to MND is obviously a big step forward, but you're absolutely right to talk about now putting it into action as quickly as possible.
Thank you. Thanks,
Thank you. Luciana.
Thank you, Chair. Secretary of State, last week you set out a much-needed new vision for cancer and improving outcomes. Can you say a bit more about that plan, and when will you publish it?
Yes, thank you very much for asking about cancer. I mean, I think that in general, in cancer, there's a lot we can be proud of as a country. But if we're honest, that when we compare to cancer outcomes in the UK versus other advanced economies, we're not doing well enough, particularly on early detection of cancers. We are working on a new plan. I want to be a long-term plan on cancer. I want there to be, I think what I call the war on cancer. I mean it. I want it to look at every different levels, early detection, of course, but new treatments as well for those who sadly, when the cancer progresses, and more focus also on diagnosis as well. I couldn't tell you right now what's exactly in that plan. I have started work with colleagues in the NHS and the department and other stakeholders, academics and others, to learn more about what we could do in that plan. You'll be aware that in the NHS's long-term plan, there's already a plan the government set out till 2026. And I want to set out a longer-term plan going much further than that, and then start the investment for that. What I can tell you, the kind of things it will include, because that clearly would be of interest, is a much bigger focus on early diagnosis. So, for example, I was really positively pleased to learn recently that the work that we've been doing through early detection of lung cancer through the lung cancer, what I call mobile vans, literally mobile units, diagnostic units, and we sent them into areas where there was a high incidence of cancer, typically where smoking rates are particularly very high. The detection rate is soared from something like, that hold me to it, was something like 30% to 80%, and that's a fantastic result. So we can really make a difference with things like that.
So the community diagnostic hubs are really welcome, and I have one in my constituency. Are there plans to increase the diagnostic capacity to improve cancer outcomes, and will those plans be within your
absolutely it's going to be so I mentioned this lung cancer mobile units is one example. The community diagnostic hubs, we've already opened up 69, and there's another, at least we want to get that to 100 this year, maybe more, and that helps a lot because you can be referred directly to one of these centres without having to necessarily go through your local NHS, and that's already in operation. And also there's trials we're doing of new technology, new ways of looking at things. The Grail test, which is with a trial at the moment, looking at taking blood samples and then trying to detect from that the risk of cancer to certain people that would, for certain reasons, be deemed to be high risk. And that is going, and that's the first in the world. We're world leading in that. And I'm also trying to see, as well as that, what else can we be doing that we break through technology and really help with early detection.
Thank you. I just want one final question, please, Chair. I want to push back on your answer to colleague Dean Russell about mandatory vaccinations. You've said you're committed to mandatory vaccinations for NHS staff. If staff do not come forward in the way that you described, if they do not come forward for vaccinations, what's going to be the impact on patients? And are you comfortable with dismissing staff who have served the NHS so fantastically during the pandemic?
I think it's a really important question if I may just take a minute on this, it's a really important question. That the whole principle is about patient safety. Yeah, that's what motivates me, and that's what motivated the government in this decision. It's about patient safety, and that principle is unchanged. That patient safety must come first. But what you've highlighted there, Ms. Allen, is that when it comes to patient safety, you've got to just think about the benefit of vaccination. We've talked about that. But also the possibility that some people, like the cost element, if I can call it that, of some people may ultimately not get vaccinated despite whatever information you provide them with, whatever reason they don't get vaccinated, and the cost of them leaving, because it would be a cost. No one wants anyone, not one person, to leave the NHS because of this reason. When we made this decision, that was the principle, and we weighed it up. The dominant variant at the time was Delta. Right? That was the dominant variant. The dominant variant now, in fact, almost all cases are Omicron, and people have already have had representations made to me, not surprisingly already, where people have said, "Look, Omicron is COVID, but it's very different in somewhat key ways to Delta," and of that, of course, that's correct. That's factually correct. We know now that Delta, on the one hand, is more transmissible, which might mean, again, emphasize the importance of vaccination. But on the other hand, it's intrinsically less severe. It's not completely, for some people, obviously, it is severe, and it certainly is for the 15,000 people in hospital with Omicron, but it is less severe than Delta. So the principle hasn't changed, but people now, the representations I get are, some people say that you should add boosters to your mandation if you're going to do it. If you're going to do it, then add boosters, because the government and others have already set out the evidence of why 2 vaccines aren't quite good enough and you need 3. So some people say add boosters. Others say, why didn't you drop mandation altogether? I think it is right, in light of Omicron, that we reflect on all this, and keep all COVID policies properly sort of under review, and because Omicron is different to Delta. Equally, we don't know what the next variant is going to be. We talked a bit about that earlier, but we are reflecting on all this.
Thank you, Chair.
Thank you. Paul Bristow.
Thank you, Chair. Secretary of State, forgive me if you talked about the elective recovery plan before I arrived. I just want to ask you a question. There's been a report that NHS leaders are resisting what they call ambitious targets contained within any plan. Do you agree that ambitious targets should be included in the elective recovery plan to focus minds? What would happen if an NHS trust failed to meet these targets?
I do agree that there should be ambition. Absolutely, I agree. I mean, there's lots of reasons. Not least, I want to get through as many electives as I can. But also, there's a lot of money being put into electives, and we have a duty to make sure all of that is being well spent, and we're getting the most. The taxpayers getting the most out of that. In terms of reports about resistance, I have to say I haven't seen that yet. I haven't seen that. Now, I'm not, obviously, the NHS, you have NHS England, you have all the various sort of trusts underneath it. It's not as though I would speak to every individual trust independently, but I haven't seen evidence of that. In fact, I would say the opposite at this point. In working on the elective recovery plan, which we will publish, that we've seen very good cooperation and work with the NHS, good partnership work.
And as I say, in the second part of my question, what if these targets are in place? If what sanction, if you like, or encouragement is there for trusts who fail to meet those ambitious targets?
Well, I'll say a couple of things. I mean, first, in terms of incentives, that making it as easy as possible to try and reach the targets. It's the kind of things that some of the things I've mentioned already, new ways of doing things. So we need some new ways of doing them. We've already started some of those, which is the community diagnostic centres, the 44 surgical hubs that we've already opened up during the pandemic, greater focus on digitisation and all that. This is all important part of it. In terms of you talk about sanctions and the way I would look at it is we've got to do everything we can to make sure that the leadership of every trust is as good as the best. There's a big variation in leadership, and already in the job I've seen trusts that I think are remarkably well run, and you really see the results even before the pandemic. But especially they've been tested a lot during the pandemic, and they've come out of it, with great leadership. But also I've seen other trusts that are just consistently, I think, failing. They're failing local people. They're failing whether it's delivering on electives or other types of care, and that's a problem. And that's why I got the leadership review. That's why there's an independent leadership review going on, because I want to see how we can replicate the best and spread it throughout the NHS. But one other final thing I would like to say in that is that we must be radical in the changes that we make. That elective waiting list is huge. No one wanted to see a waiting list at this level. We all understand why we've got this COVID backlog. But if we are going to get through it far quicker than in the past when we've had such waiting lists, we've got to be radical in the changes that we make and how we make them. So, for example, digital technology. We're not making the most of it. We've got, during the pandemic, we had some, I think, like over 25 million people download the NHS app and use it. And now that's just one example. Just think of what we can achieve with that in terms of the patient NHS relationship, in terms of the information to them, the transparency, seeing them more quickly. That's just one example about how we can improve patient choice.
Last one. And there's a sort of thought that targets lead to perverse outcomes and perverse incentives. Actually, I'm a huge fan of targets because I'm a huge fan of transparency and accountability. Will you regularly report, or will NHS England regularly report on achievements against any targets that are contained within the elective recovery plan?
Yes, we will. And also just on the value of targets. Of course, the targets work if they're the right targets.
That's right.
And in the NHS, I already noticed there are targets which are the wrong targets, and we've got to change them. The 4-hour A&E target is the wrong target, right? It doesn't work. It leads to really perverse outcomes. If you look at some NHS trusts, all of a sudden when the individual in A&E has got to 3 hours and 55 minutes, guess what? They're just admitted, right? And that's a poor outcome. And there may have been a good reason to have that target in the past, but you've got to keep these targets constantly under review, and that's something I'm doing.
Okay, good.
Thank you. And last but not least, we had some questions from members of the public that have asked us to put them to you, and so I'm going to hand over to Laura Trott for the final set of questions.
Thank you, Chair. Welcome, Secretary of State. So I'm going to read the 5 questions which were asked from the public, and I would appreciate, given that the Minister's on his feet, some fairly brief answers if you can. The first one is from Marina. With the restrictions being lifted, when are births being reviewed? It seems nothing's changed since 2020. To sit alone with your thoughts for hours, waiting to go to theatre is not right. Both of us would have had PCR tests. Why is my partner having to wait outside the hospital?
They are being constantly, that issue has been constantly reviewed, and there have been significant improvements as we've learnt more during the pandemic with the protections that we've got, with the testing, for example, and PPE, and it is something that with the Omicron wave, I know the NHS has looked at seeing how they can make even further improvements.
And can I ask more broadly on visitors when you are planning to review restrictions? Because obviously family and friends are advocates for patients, and there's a real significant deficit in care because they're not being able to come in with them. When are you going to be able to remove those restrictions within the NHS more broadly?
When we set out the Living with COVID plan, we will have a lot more to say on that. We're not just going to wait for that. And if there's any improvements that we can make in the meantime, we will. But it's the tricky bit is always trying to get that right balance between you're protecting patients, but also making sure that their loved ones can come and see them, and because everyone, the benefits not just for the patient but for the whole family from that. And the rules are set by the UK HSA, the Infection Protection Control rules, and they are constantly under review. And you will have seen through Omicron that when Omicron began, we brought them in to try and control the rate of infection, particularly in hospitals and care homes, and now we've gradually started to move back from some of those rules.
Can you guarantee that they won't be there in the long run?
I think we need to learn, as we learn to live with COVID, we need to make sure if there's some obvious things we should do differently in terms of infection protection control, then we should keep some things, if they make sense, keep them in place, because it's not just COVID infection. That if you're in hospital, for example, there may be things that we've learnt from COVID that we actually think, maybe we weren't doing protection from infection as well as we could have in hospitals, and so maybe there's some simple things that we can continue. But as a general thing, I think we should try to remove as many of the COVID sort of rules and regulations as we possibly can, as long as it's safe to do so.
And moving on to the second question from Jarosha. When will which you've touched on slightly already, when will the elective recovery plan be published? Will you commit to a ring-fence cancer nurse fund to double the number of cancer nurses by 2030?
The elective recovery plan, I was planning to publish it in December, then Omicron came along, so I hope to get it out as soon as I possibly can in the next few weeks. I just can't commit to a specific date today, but it's a priority and you shouldn't have to wait too long. And in terms of ring fencing spending for a particular part of the workforce, albeit a very important part of the workforce, as a general rule, I think ring fencing is not the right way to go. It might sort of sound good, but I think it's important to let the NHS, when it's looking at all its needs, to decide how the funding it's got for workforce, how best to allocate it.
Third question is from Paul. How much of the 36 billion extra funding for the NHS is going to dentistry?
I couldn't tell you how much of the 36 billion. I don't think actually much of it will be going to dentistry, because it is very focused on electives, and 8 billion of it, 5.4 billion on adult social care, about 10 billion, just under 10 billion on vaccines and therapeutics and PPE, and then there's a big chunk, 4 or 5 billion of it that goes to under the Barnett formula. But dentistry is hugely important. It's a priority, and that's why just today I announced an extra 50 million, paying for 350,000. I was going to say procedures, but fillings and things.
Fourth question is from Stephen, who asks, what steps is the government taking to reduce the racial disparities in the use of the Mental Health Act?
In the use of what, sorry?
The Mental Health Act.
In our current long-term plan in the NHS, there's changes that is a recognised issue, because there are some serious disparities. But I think that the bigger change will come through our plans with the reforming the Mental Health Act, because I think the way that Act is structured has led to some of these, inadvertently, to some of these challenges. And if I can say more broadly, and I know this is about mental health and racial disparities in mental health, and that's really important, but also there are concerning racial disparities in healthcare for me that I've noticed, certainly more broadly. Recently, I've set out some of the concerns I had over pulse oximeters that were used during COVID, and how if you had darker skin, they weren't necessarily giving the right reading. And I think it might have been a reason why we saw a disproportionate number of black and minority ethnic people in hospitals, certainly in ICU, and clearly that's not acceptable. And I think I've said already, I want to review this properly, independently, around medical devices as well, and racial disparities.
Thank you. Final question from Nigel, which is covered slightly in the questions with Sarah earlier. What is the workforce plan for social care? How will it address pay, reward and recognition?
The social care plan, there's two elements. There's a short term and the long term. In the short term, there's extra support because of the pandemic, essentially. We have a shortage of social care workers, and a lot of that is that short-term support, the funding I referred to earlier. But the long-term plan is the extra 500 million being allocated through the levy, which will go on many aspects, including workforce training.
Thank you. Thank you.
Thank you. Just a final question from me before we wrap up. I noticed you said that you wanted to have a war on cancer, and it was exactly 50 years ago they launched a war on cancer in the United States. Yeah. I'm tempted to ask whether you've drawn any other inspiration from President Nixon, but that actually isn't my question. My question is going back to GPs, which we touched on a bit earlier, because we're doing an inquiry into general practice. It hasn't opened yet, but I wanted to ask you, because you've talked about long-term reforms that you want to look at for the NHS. Yeah. Last year there was a study in the British Journal of General Practice, an enormous study actually conducted in Norway, which said that if you have the same doctor, the same GP over many years, you are 30% less likely to go to hospital and 25% less likely to die. And today there was another survey, also in the British Journal of General Practice, of 9,000 dementia patients. And it said that if they have the same doctor over a long period of time, they have a 35% lower chance of getting delirium. So I just wondered, when you look at potential reforms for the NHS going forward, will you consider whether, as we increase GP numbers, we could go back to GPs having their own lists of patients as they used to, so that everyone has their own doctor?
Yes. I read a report of what you've referred to. I think it's a report of the report. And it's something to me, instinctively, it sounds like a common sense approach. You know, it has to be the case that if you are able to see the same GP regularly, that as he or she learns more about you, that you better look after you. Now, I couldn't make a guarantee that we can do that. I think in primary care there are a number of issues that we need to look at to make improvements for patients, but that should certainly be one of them.
Thank you. Well, the bell has rung. Perfect timing. Thank you, Secretary of State, very much indeed. I declare the session over. Order, order.
The proceeding has ended.